Talk about some heart blocks.
Oh.
What is a heart block?
The atrium and the ventricles are not communicating.
All right, so atrium ventricles have lost their communication skills. So it's supposed to be like atria pumps and then tells the ventricles, your turn. So bump, 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 bump. But this time they're like, bump. And he's like, I'm not going to do what you say. Boom, I'll go when I want, right? So there is first degree, second degree type 1, second degree type 2, and then third degree. So as we go along, obviously it gets worse and worse between the two.
Yeah.
They get further and further apart. They're going to divorce. I'm sorry. All right, so let's start with first degree heart block. Is anybody panicking?
No.
Nope. Everybody has problems in their relationship. Yes.
Yep.
So just because y'all ain't talking for a minute because he talked to so-and-so and he likes someone's photo on Instagram, like it doesn't matter. Okay. Nobody cares. What's our heart rate going to look like?
Normal.
It's going to be normal. So it's going to be 60 to 100. What's the PRI going to look like?
It may not be there.
It's going to be more increased, right? Because what's happening is the atria are going to contract, but they don't tell the ventricles it's their turn, right? So the atria is like, and then the ventricles are like, Do you see what I mean? So you see how it's going to be increased? It's going to be longer is another good adjective we would use for it. Yes, indeed. Do you understand why the PRI would be longer? They're starting to not communicate as well, right? You know, at the beginning of the relationship, everybody talking, right? Text. Then it's just, so she texts and he's like, I'm at work, I'm busy. You understand? Okay.
Yes.
So that's the PRI. So the QRS is still going to be, are the ventricles still doing their thing?
Yes.
Yes. So this is why we don't panic about heart blocks, because the ventricles are still doing their thing. They'll do it when they want to do it, but they're still doing their thing. Clear?
Yeah.
So the cardiac output is
Fine.
still good. Okay.
Yep.
Okay. So is the heart rate regular?
Yep.
Yes. Okay. It's just maybe longer between the atria and the ventricles contracting, but it's the same length of time every time. Okay. Are they stable?
Yep.
Yes, they are. They're having a bad day, but they're stable. Okay.
Yep.
Okay. What are some causes of a first degree heart block?
Aging.
Aging. Okay, I can agree with that.
They're just getting tired.
Okay. Myocarditis can do it. That's a hot topic right now. So myocarditis, which is what?
Inflammation of the
Inflammation of the heart
Muscle.
muscle. Okay, so muscle's a little mad. So the atria, and the ventricles are like, why mad? Okay. High potassium. Why would that cause a heart block?
Slows heart. Affects contractility.
It can affect the contractility and the electricity, right? And that electricity has to start in the SA node and go down the line, right? So it goes from the SA node, which is in the atrium, to the AV node, which is between the atrial and ventricular. That's why it's called an AV, right? Okay, so there's something happening with the electricity, right, where it's not conducting correctly. So the SA node may be going off, but then it's like slow, boom. You understand? Okay. Beta blockers and calcium channel blockers, if you have too high of a dose, that can cause a first degree heart block, because what do both of those do? Slow your heart rate. Okay. And so they may forget how to communicate with one another. Okay. Okay. All right. Do we do anything for first degree heart block?
No.
No, we are just going to go home for the day. Thank you. Not right now. Don't leave. Okay. So we're just going to watch it. Something we just keep an eye on. Okay.
Yep.
Okay. So we're going to go into second degree type 1, also called
Winkins.
Winkins.
It's like Winix or something.
So,
I know it starts with a W.
Winky Bach.
Winky. Close enough.
Winky Bach. She's like, close enough. Okay, so in second degree, now we're getting even further and further apart. So before we were just having some relationship problems. I text you, he texts back whenever he wants, right? Now it's like, we're just not seeing eye to eye. I don't really even like you. I will respond whenever I want to, and we're going to keep getting further and further apart. Do you understand? Okay. So then she texts him in the morning and he says, I'm at work. Don't bother me. And he won't text her till the end of the day.
So it drops the QRS?
Sometimes, but not always. I will show you. Okay. So, heart rate is normal. Okay. Or it could be less than 60. How come?
If they're not communicating, then
because the ventricles go off when they want to go off, and we're counting the QRS complex to do the heart rate, correct? Okay. So the atria is like, nah, and then the ventricles are like, yeah. Okay. So it may be less than 60, or it could be that it's still the same. Got me? What's the PRI going to look like? long, right? It's going to keep getting longer and longer because we're getting further and further apart because the P wave stands for atrial. The QRSs are ventricular, right? So the PR interval is between the P and then the middle of the QRS, right? So that's how well the atria and ventricles are communicating. They're not. So it's going to be very long because the atria are going to go, and then the ventricles are going to go, you understand?
Yes.
Okay. All right. I don't know how y'all are going to write down all these noises, but this is where we're at. All right. Is this going to be a regular rhythm? No, because he decides every day when he wants to text her back, right? Every single day, like I'm busy. I went to the gym after work, whatever. Yeah.
Yes.
Okay. All right. Are they stable?
Yes.
Yes, because most of the time at this point, they're asymptomatic. It hasn't gotten so bad to where it's really affecting cardiac output. So most of the time it's still going to be they're still stable. Okay. What are some causes of second degree type 1 winky back?
Old. Potassium.
You just like to say everything. Okay, so elderly is a big one. Potassium doesn't usually cause this one because by the time we get to second degree, this is usually pathological. Okay, so it could be that you're on massive dosages of beta blockers and calcium channel blockers. It's slowing down the heart too much to where the A and the V can't communicate.
Okay.
Yeah, don't you remember studying beta blockers? One of the biggest side effects is AV block.
Yes.
Okay, all right. Why would hypoxemia cause a heart block?
No oxygen, so your heart's trying to like compensate for that, and then it gets.
What?
Okay.
If you're not getting good perfusion to your heart muscle, right, is it going to be able to conduct electricity correctly? No, it's not. Why would an MI cause a heart block?
Scar tissue.
Scar tissue, because we know scar tissue does not do two things. Number one,
Stretch.
it doesn't stretch, so we can have a contractility problem. And number two, it does not conduct electrical impulses correctly. So it's going to take a lot longer for those electrical impulses to get through because they don't conduct through scar tissue. Do you understand? Okay. Do y'all remember a big adverse effect of digoxin?
AV block.
Yeah, AV block. The way I asked it kind of made it easy, didn't it? Okay. So digoxin, what is its job?
Contract.
It increases contractility and decreases heart rate. So it may decrease the heart rate so much that the atria and ventricles are no longer contracting. If you go into dig-tox, remember in dig-tox, you have 3 sets of symptoms that you're going to present with. We try to catch it in stage 1, right? What's the first set of symptoms you see in dig-tox?
Nausea.
Oh, you may see bradycardia, but nausea, vomiting, anorexia. That's good. So in the second set, if we didn't catch it at that point, then they're going to start to see
spots,
halos around the lights and weird colors and what is happening. And then the third set, severe bradycardia and AV blocks. Now the atria and ventricles are not even communicating anymore and the heart rate's going to go really low. Are y'all with?
Yes.
Okay. So what are you going to do?
Pace. Oh, nothing.
We're not there
They're
yet.
stable.
They're stable, so we're going to keep an eye on it. Okay, so the way to remember type 1, it's winky buck, right? So what they'll do is it goes longer and longer and longer until eventually it will drop a QRS every once in a while. Okay, so that means like he didn't text her, right? And then he goes to work, then he goes to the gym, and then one night he just didn't come home. That's rude, right? Yeah. So a longer drop. Now we're in winky buck. Okay, longer drop. Now we're in winky buck. So what you'll see is if y'all want to actually look at this rhythm, right? Look at the rhythm. You can see that the QRSs, you see where they dropped? Yes. All right. So they're going to get, and you can look at the P wave on this. So you can see in the first QRS complex, the P wave is very close to the QRS. Then you can see it gets further away, and then drop.
Okay.
Y'all see that?
Yes.
Okay. And then it's going to keep doing that. Yeah. Okay. Now, if a patient does happen to be symptomatic, what kind of signs and symptoms do you think you're going to see? What's their heart rate going to look like?
Brady.
It's going to be low, right? Which can cause them to have either poor perfusion, low blood pressure, because their cardiac output's not going to be that awesome, right? If their heart rate's really low. Yes. These patients may faint. What is fainting called? Syncope, right? But still, if they're symptomatic, we may consider pacing, but not usually for second degree. Okay. All right. Do we understand second degree type 1? What's your rhyme?
Drop, drop, drop.
Longer, longer, longer drop. Now you're in Winky Buck. Oh my God, this is such a good day. Okay, so we're gonna go into second degree type 2. This is called mobits. I don't have a good rhyme for mobits. There's not a lot that rhymes with bits. Now we eat Brits. Yeah, okay. I'll think of it. I'll think of it. All right, so at this point, we're getting farther and farther away. They're dropping QRSs. Kaboom, kaboom, kaboom. So now he's not coming home like 3 nights a week, which means he's probably with, you know, homewrecker, Sumner. Okay, so well, heart rate is going to be less than 60, right? Because we're going to be missing beats, right? Our QRS complexes are dropping more regularly. Yes?
Yes.
Okay. They may start to be symptomatic at this point, but are they stable for the most part?
Yes.
Still, yes. And some people don't even know they're in it,
Yeah.
right? They're just like, oh, I feel faint sometimes. That's weird. Moving on, right? So they are stable, but they may start to have symptoms if their cardiac output starts to be affected. Now, what would cause their cardiac output to be affected?
Heart rate.
The low stroke volume, low heart rate, right? Yes?
Yes.
Oh, ding. Okay.
Oh, no, I'm right.
Causes of second degree or mobits heart block. Now, this is big ones. Something happened between the atria and the ventricles that caused, like, we are not talking at all what usually is there.
Could it be like stenosis?
No, it's
Mitral valve stenosis?
no, this is not a mechanical problem. This is electrical.
An MI?
A massive MI that you had, right? And it could be a previous MI where there's now scar tissue, right? Scar tissue does not conduct electrical impulses. You weren't wrong when you said that. Okay. All right. So, or this could be that they're having acute cardiac ischemia, right? There's no blood flow to that area. The heart's like trying to get electrical impulses through there, but it's like, wait, there's nothing there. Got it? Okay. What is your priority for this patient? If you plug them into an EKG and you're like, oh, they're in second degree mobits. Okay.
Check for perfusion.
We're going to check for signs of perfusion. That can pretty much hold you for any exam, right? Almost every single one of these dysrhythmias, our big fear is making sure they're getting perfusion. So you really can't go wrong with checking for signs of perfusion, right? At least in our ventricular dysrhythmias and our heart blocks.
Yes.
Okay. What are we going to do?
Pace.
Watch. Because most of the time they're asymptomatic, right? If they're asymptomatic, we're not just going to do something.
Okay.
Okay. So y'all can turn, you can take a look at this rhythm if you want to. So in Winky Bach, it was like longer, longer, longer drop. Now it's like longer drop, longer drop, longer drop. Cause he only comes home like every other night.
So there's more drops than that.
There's many more drops.
Okay.
Okay. Do y'all see where the arrows are pointing is going to be where we're dropping, right? You can see a big space between those QRS complexes.
Okay.
Okay.
If
All
they
right.
had a previous MI, would you be looking for like the Q wave or the U wave
Well, they've had
on there as well?
oh, sure. You can look for a pathological Q wave or a U wave, which means they've had a previous MI, but that basically just tells me like a long time ago you had an MI and it probably didn't get treated. So it may or may not show up on there. But yeah, definitely something you look at. Yeah.
Okay.
All right. Now we're going to go to the Big Daddy. That's third degree heart block. Now this one's impressive because now it's like, okay, so in second degree type 1 or Winky Bach, it went longer drop. Now we're in Winky Bach. And then in second degree type 2, which is your mobits, he just like drop, I'm here, drop, I'm here, drop, I'm here, right? And now he's just like, I don't know why I'm going back and forth to this hotel. I might as well just stay at the hotel. He'll come home every once in a while to like get a muffin and some shorts. You understand? Okay. All right. So third degree is like, they're not talking at all. I mean, this thing is not working out. He only comes home to get what he needs. And then he goes back to the hotel with Miss Thing. Okay. So heart rate's going to be Brady. Yeah, definitely it's going to be on the low side. Eh?
Yes.
Do they have a PRI?
No.
I mean, not really, because you don't know when it's
Yeah,
just
it's
dropped.
so far
Yeah,
apart.
it's too far. QRS.
Have it sometimes.
But they have, yes. So when they have it, the QRS is
Fine.
normal, right? Because the ventricles are still firing well. There's nothing wrong with the ventricles, right?
It's just, yeah.
Ah.
Yeah.
Yeah. Is this a regular rhythm?
Is it regularly irregular?
It did, no, it's just either it's regular or it's irregular. So is it regular or irregular?
Irregular.
She's like, based on her face,
Throwing out.
it's going to be considered a regular rhythm. It's just a very slow rhythm, right? So it's like beat, beat, beat. So you can like kind of tell when it's coming, right? Do y'all see what I mean?
Yeah.
Okay. Are these going to be stable at this point?
No.
Not of a heart rate of 30. No patient is going to be, sup y'all. Okay. So there's a lot of different causes of heart block. We've already talked about several of them. So give me the ones we've already talked about. They could have had an MI. They could be on calcium channel blockers or beta blockers. They could be in Digitox. That's a big one. Yes, it is common for elderly clients to eventually get a heart block from heart disease is what it usually is from. Sometimes we will see a heart block with TCAs. What are TCAs? Tricyclic
There's like drug.
antidepressants. Those can cause heart blocks. Okay. So it usually is either they're very elderly or there's some kind of medication issue is mostly what we're going to see for heart block. Okay. Now this is kind of a big deal because your heart rate is obviously not enough to, so the first thing you're going to do is to check for signs of poor perfusion, which there probably will be. Okay. Now I can't make them communicate anymore. Right. So what's the only thing that we can do? We're going to have to get a pacemaker. Now you can do a temporary pacemaker, or they can go in and go ahead and put in a permanent pacemaker if this is an elderly issue, right? If this is just how your heart's going to be. Okay. In the meantime, because obviously a pacemaker is a surgical thing, you can do transcutaneous pacing. Well, they'll do it through the skin, right? And they'll just be like, hey, beat when I tell you to. Okay. But we have to put them on some kind of meds because right now they have signs of poor perfusion, and that's not good. We can't wait for surgery for that, right? So what do you want to do for this patient? We're going to give atropine because that's going to increase heart rate. Okay, what are other options? Epinephrine can increase our heart rates. And oh, you really like that one. I wouldn't give norepi only because it works more on blood pressure. Huh?
It also increases the contractility.
What?
Epi.
Oh, yes. Epinephrine does also increase the contractility. Yes. And then we can also use dopamine. So, dopamine also helps to increase heart rate and yeah, but it doesn't work. It does increase contractility. Don't get me wrong, but it doesn't work as good on contractility as dobutamine, right? But I don't really need a ton of contractility because the ventricles are still pumping well. I just need it to like get a little more excited and start communicating. Okay. Do we understand third degree heart block?
Yes.
Do we understand heart blocks in general?
They told us that we couldn't use